Thanks, Russell, and thank you all for being here today to learn about some of the research that we're doing in GI cancer, and to also kind of get an insight, I think, into how these things kind of work and what these big international meetings are about. So I'm going to talk specifically about colorectal cancer. As Russell said, I'm very keen for people to ask me questions as we go through, and at the end, and just one-on-one if you want to sort of ask me sort of questions away from the big audience. But I'm sure all your questions are very good questions, so don't be afraid to ask me questions. Now, ASCO stands for the American Society of Clinical Oncology, and it really is more than just an American society now. It's an international society. It's a huge meeting. As Russell said, we get somewhere between 35 and 40,000 delegates coming there, and the numbers now are roughly 50-50 of American delegates versus international delegates. And there are always plenty of Australians that go there. In fact, I kind of do most of my meetings with Australian colleagues in Chicago. I'm from Adelaide, and so it's a good chance for me to catch up with people from Brisbane and Sydney and Melbourne, because there are quite a few Australian clinical researchers in cancer over there. And it's a broad meeting. It covers every sort of aspect of cancer, solid cancers, GI cancers, hematological cancers, cancer prevention, cancer services. Anything to do with cancer is usually presented at ASCO. And it's also the premier meeting where new treatments are discussed, new clinical trials. And it certainly offers an opportunity for us to get together and communicate and collaborate with other like-minded researchers across the world. And I'll talk through a few studies where these studies are really a kind of a joint multinational project. And so you need a kind of a platform like ASCO to allow this sort of thing to happen. So Chicago is where the meeting was held, and it has been held there for the last 8 or 9 years. For those of you that have been there, it is a kind of an impressive city with the skyscraper skyline. The conference centre is about 5 miles from the city centre. Most of the big hotels are in the city centre. And to try and keep fit, I used to walk to the conference centre and back. It was a good sort of hour walk. And this is part of the walk, so you kind of see the skyline, and that's Lake Michigan as you're walking across. And there's a nice pedestrian sort of pathway. So if you're ever in Chicago, go to the park and walk along the lake, and it is quite a pretty city. This is how it looks at night. This is the river that runs through Chicago. One of the central kind of landmarks now is this hotel building called the Trump Tower. So Trump certainly has a kind of a presence in a city like Chicago, but it is an impressive city by night with all the lights and everything. Now, this is the conference centre, and this is a photograph that I took. I was kind of very close to the front of the conference centre for what amounted to the final session of the meeting. It was the Tuesday morning. The meeting starts on a Friday and it finishes on a Tuesday, and the big main colorectal cancer presentations were on the Tuesday morning. And I sat towards the front of this and turned back and took a photograph just to show you what it all kind of looks like. And also it kind of demonstrates a few interesting things. Firstly, there are people from all over the world there, and we're kind of doing things kind of out of hours, and we're pretty jaded and jet lagged, particularly towards the end. And you can see this fellow here who sort of laid his head back, and you kind of need to if you're towards the front. It's like being at the front of the cinema, so you're kind of looking up, and that's kind of a dangerous position because you lay your head back on a chair and you can close your eyes. The other common thing that you'll see are people like this who have got their heads down on the screen. No matter where you go nowadays, people will have their heads down on the screen, and even though they've travelled halfway across the world and they should be looking at the big screen and what's going on there, there's stuff going on there. But having said that, they now link it all in, so you can actually see a lot of the data on your screen. You can actually present questions to the speakers through your phone. So the technology is being used sort of in that way. But most people are paying careful attention as they should. So I thought, in terms of going through the data, I'd start off with going through a series of three separate studies that really all asked the same question. They were done by different groups. The answers were a bit different. And I just thought I'd use this as an example of highlighting how we do this research and how we try and make sense of the information that we get out of the research and where it all kind of leads to. Now, the first study that I'll talk about is a study that the AGITG were involved in. It's known as the PETAC-6 trial. This trial emanated out of Europe and several European cooperative study groups. Groups like the AGITG were involved, as was the AGITG. And this is a study that's specifically looking at patients who have rectal cancer that is restricted to the rectum. It hasn't spread. And it was asking a question, a clinical question, and that question really was, should we be treating these patients with one chemotherapy drug, or would we get a better outcome if we used 2 chemotherapy drugs? Now, if you add a chemotherapy drug, you'd think you'd get a kind of a more powerful anti-cancer effect, but you may also get more side effects. And we just really didn't know whether the second drug was going to give us enough extra bang for the extra cost and toxicity. So you really need trials like this to demonstrate that the strategy of upscaling the chemo is beneficial. The main drug is a tablet called capecitabine, which we use commonly in Australia. So that's part of the standard of care, if you like. The drug that was experimental was another drug that we use more so in the treatment of advanced bowel cancer, and we do use it in the treatment of stage 3 colon cancer, but its role in the treatment of rectal cancer has been a bit unclear. So this study looked at patients getting either just the tablet, both before and after the surgery. They have surgery as well to remove the cancer. Patients also get radiotherapy before the surgery, and so the tablet's given with the radiation therapy before the surgery. So half the patients received just the chemotherapy tablet. The other half got the injection drug called oxaliplatin, given with the tablet before the surgery and after the surgery as well. So we wanted to know whether adding in that second drug was going to make a difference. The results of giving the oxaliplatin with the chemotherapy before the surgery had already been presented at a previous meeting, and that finding was interesting in that it didn't really demonstrate a benefit in giving oxaliplatin before the surgery with the chemo tablet. So this now is looking more specifically at what about after the surgery? What about if we give the combination of the chemotherapy drugs after the surgery? Will that further reduce the risk of the cancer coming back? Now, this study involved just over 1,000 patients. That was a fairly large study. And you know, when you're doing a study that's going to be that big, this is where you need this kind of collaboration. You need the groups to come together to make it happen. If one group tried to do it alone, the study would take 4 or 5 times as long. The answer would take 4 or 5 times as long to get to. So we want to get to the answers quickly. And this is why collaboration is so important. And that involves coordination. That involves the sorts of meetings that Russell was talking about at meetings like ASCO, where we meet up, the various trial groups sit together and work out how are we going to do this. And then when the data comes through, we kind of sit down and work out how are we going to sort of analyse this and what does it all mean and how do we present this. So there's a lot of communication that goes on. Ultimately, we all want to find the truth. But the truth isn't always easy, so we'll sort of talk about that as we go through the results. Now, this is really the headline result from this study. They looked at the risk of the cancer coming back both around where the primary cancer sat, so around the lower part of the abdomen, the pelvis. They also looked at the risk of the cancer coming back in other areas, because it can come back in the liver, it can come back in the lungs, it can come back in any area. So we looked here at a particular endpoint, at the 5-year time point. What was the chance of having the cancer come back locally? What was the chance of a relapse in a distant site? And what you can see here is that the CAPE alone, the capecitabine alone, the top one here, don't have the pointer, sorry, is a little bit higher than the bottom one. So in other words, the risk of a relapse is lower, was lower numerically, when you give the combination of. So you think maybe the combination is better. However, when we look at the statistics here and we look at the magnitude of the difference, it's small. We're talking about a difference in the risk of a relapse or the rate of a recurrence. It's only in the order of about 2%. And you know, that might be significant. If you do a really big study, though, to demonstrate a difference that's only 2%, and you want to demonstrate that it's a true difference, you really need a very large study. This was a very large study, but 2% wasn't a large enough difference for us to sit back and say, you know what, this is real. This difference is a real difference. These numbers here, we call them p-values. They give us an idea of the chance that this difference is just a chance finding. You know, when you do a study, one's going to be better than the other slightly differently. You're not going to get exactly the same number. So what if that difference of 1.5 to 2% is just a chance? This tells me that there's about a 24% chance this is just down to chance. There's about a 26% chance that this difference is just down to chance. It's not a big enough difference for a conclusion to be drawn that the addition of the second chemo drug reduced the risk of a relapse. So it's kind of a negative study. Maybe we don't really need that second drug. Or maybe there is a difference of only 1 or 2%, and maybe it would have been significant if we had not 1,000 but 20,000 patients in the study, which is probably not going to happen. I'll come back to this at the very end, where we start talking about, you know, a difference that is statistically significant maybe, or not, and a difference that's clinically significant, meaning that, you know, if this 1 to 2% difference is a real difference, we're reducing the risk of a recurrence by 1 or 2%. So if we treat 100 people, we've prevented a recurrence in 2 of them. That could be a real big benefit, and some people would look at that and think, hey, you know, I want that, because I could be one of those 2 people that won't get a recurrence if I have a second drug. We need to factor in the cost, and the cost that I'm thinking about here is toxicity, because that second drug causes a lot of nerve damage. And is the 1 or 2% benefit sufficient to take on board that extra nerve damage? So that's an interesting question, and one of our researchers here in Australia actually was trying to ask that question. I'll come to that right at the very end. So PETAC6 didn't show a benefit, and this is another statistic from that study, and this is where the curves look very kind of identical now. Now there isn't that much of a gap. In fact, these are really the same. This outcome takes into account both a recurrence locally, both a recurrence at another site, and a death from any other cause. And when you add in some of those numbers, you see that there's no real difference. So this study, the PETAC6 study, did not support the use of the second chemotherapy drug. There's another photograph from ASCO. So yeah, the one that I showed you before was more of an auditorium, more of a kind of a lecture theatre style thing. Many of the rooms are these big kind of hangar rooms, and they can fit, you know, somewhere in the order of 5, I think up to 10,000 people. They're kind of massive. Now this is another study, and this is really asking a very similar, or basically the same question, but focusing on the treatment after the surgery, again for rectal cancer. And this was from Korea. They did a study where they again asked, should we be giving just the 1 chemotherapy drug after surgery to reduce the risk of the cancer coming back, or should we be giving 2 drugs? And here they got a different result. This time the combination of 2 drugs was in fact better. This time this p-value, business that I talked about, wasn't 0.24 or whatever it was, 0.26. It was 0.018. And that's where we look at that and we think the chance that these 2 kind of not really different, and this is just a chance finding that there's a difference there, well, that chance is only about 2%. That's what that tells us. So we look at that and we think, you know, there really probably is a difference there, which is really, you know, might be kind of clinically meaningful. So this is one of the other things that we deal with in research. We deal with conflicting data from different groups. And we have to sit back and put all this together and make sense of what this all means. And we need to, through all this information, develop evidence-based guidelines and really inform evidence-based practice. And it's not easy sometimes. So we saw that previous study that might be a small difference. It wasn't quite large enough really to make it to be sort of statistically significant. This one did suggest that oxaliplatin did provide a benefit for rectal cancer after surgery. Another photograph. And you can see the sort of the multiple screens and everyone looking at the screens. And this is another study, again, really asking the same sort of thing, only with a bit of a twist at the end. This is a Chinese study. And I was impressed to see that there were a number of Chinese studies now being presented at these big international meetings. The Chinese, as you'd be aware of, big population, they're getting coordinated now and they're doing the big clinical trials and they've got numbers of patients and they can do these sorts of big clinical trials looking for small differences, sometimes fairly quickly through their population. So it's certainly good just to see the Chinese kind of there on the platform and being part of the international kind of group, because this is really all an international global effort, this fight against cancer. Now what they did is the same sort of thing. The first line across there was looking at giving radiotherapy with a drug called fluorouracil, which is pretty much the same thing as the tablet, same sort of drug. And that's all they got, the fluorouracil, the one chemo drug. The second line across there was the addition of the second chemo drug. Now we were again comparing one chemo versus two chemo. They got the two chemo drugs before and the two chemo drugs after the surgery. Now this is where they had a bit of a twist, because they had a third arm and they asked the question. We sort of take it for granted that this kind of is necessary, but they asked, how much, if we give a really good chemo regimen, a strong chemo regimen, and we do a good operation and we really remove it all, do we really need the radiation therapy? That was the question. So that was really interesting. So they had a third arm, no radiation therapy. And they wanted to see how each of these groups go. So with the basic concept of any of these trials is that you kind of follow a set protocol, a set path, and what you're really interested in is down here, how do the patients go? What are the outcomes? Now this I put up just to demonstrate something that kind of feeds in a little bit to a study that the AGITG are supporting, that Russell mentioned, the Reno study. It's the rectal cancer no operation study. Just to make the point that these patients were all set on a path to have an operation. But a significant number in each of the groups, around about 6 or 7%, said no to surgery. Now we don't have the exact details as to why, but we do know that some patients will achieve what we call a complete response clinically. You do the scans, you look inside with the telescope and the cancer's all gone. So it's just interesting that a number of patients decided not to have the operation, but they're all included in the analysis. And this study was more in line with the first study from the European group, where we didn't really see a benefit in adding the second chemotherapy drug. And this time it looks kind of, the numbers are almost really identical. What was really interesting though was that the group that didn't have radiation therapy, that just had the chemo, seemed to do just as well. So that's kind of raised a question. This study won't in itself change practice, but it does raise the question about the role of radiation therapy. And I think we need more research to work out whether that is a treatment that could be potentially avoided in some patients. We need to work out who those patients are. But sometimes we get results from trials that raise more questions, don't necessarily give us answers. So this is another nice view. It was sort of close to where my hotel was, and you've got the nice sort of river and the boat trips, and I think I was about to head off on my walk to the conference centre when I took that on a nice Chicago day. I'm going to move away from rectal cancer and just move up a little bit and talk about another really kind of challenging clinical problem to manage. And that is cancer of the bowel that has actually spread to involve the lining of the abdomen. The abdomen's lined by a sheet of what I kind of call glad wrap. It's called the peritoneum. And cancer cells can often move from the bowel and settle and plant on this glad wrap. There's an operation that can be done where with a surgeon, a skilled surgeon that knows how to do this sort of thing, could go in and actually remove this glad wrap, remove the peritoneum. It's a big operation. And there have been some studies that suggest that the operation is beneficial and that giving chemotherapy directly into the abdomen, it's heated up, it's given in through a set sort of protocol, that chemotherapy can penetrate into that lining and get rid of more cancer cells. And that may improve the survival for patients with cancer at that stage. And this is certainly something that is practiced kind of around the world. And the evidence to support this has never been entirely convincing. And the French group, this study was done in France, devised a trial where they got the consent of patients up front before they did the operation. They then did the operation, and provided they could clear the cancer, they had to clear most of it surgically. The patients were assigned, and this assignment happened through a computer or an envelope at the time of the operation. So the surgeon's in there and he says, okay, we've done our operation, it's all good, this patient's had a good clearance, I want to know now, should I give the chemo into the abdomen or not? And that process of randomly assigning the patient happened intraoperatively during the operation. And so the surgeon, they kind of had the medicine all ready to go, or they would put it back in the fridge. The surgeon was told, this patient has been assigned to the treatment. And they'd have the treatment, or no, this patient's not going to get the chemo, time to close the operation. So it was a really clever trial. We don't do very many surgical trials. A lot of our trials, I know this involved chemotherapy, but a lot of our trials involve giving chemotherapy A or chemotherapy B or different radiotherapy treatments, but this really involved the surgeons. The French did it very well. So they wanted to demonstrate that giving the chemotherapy improved the outcome for patients. It actually made a difference to their survival. Unfortunately, it didn't. So this study was what we call a negative study. The survival rate was really no different between the group that got the chemotherapy and the group that didn't. So this is the sort of study that could change practice. Now, it's one study, and there'll be others that say we need more studies before we decide to abandon the intraperitoneal chemotherapy strategy. This sort of data will be teased and examined, and people might want to look at a different type of chemotherapy or a different way of giving it before they are prepared to drop it. But I think it's just so important that we look at this sort of data and we gather evidence to support practice, because nobody wants to be doing something that's not really providing a benefit. And with everything that you do, there's a risk and there's a cost. So these sorts of studies are very important, and a negative result is still a very important result, and it may change practice. So that's intraperitoneal chemotherapy. That's another photo along the walk. It's a beautiful, neat skyline. If you sort of go along there, it's amazing how it can look so kind of ordered. It's really impressive. Now, just sticking to advanced bowel cancer, this is another study that asked an interesting question, I think, and this is more about fine-tuning how we give the chemo and how long we give the chemo for, and what kind of treatment we give. This was a study from Italy. They called it Valentino in Italian. They looked at giving everybody 4 months of chemotherapy with a recipe that we use as a standard across the world. The two chemotherapy drugs, again, same drugs that I've mentioned before, really, oxaliplatin and fluorouracil. And these patients were also patients that were treated with an antibody called panitumumab. It's an antibody that works against a particular type of bowel cancer, and that bowel cancer is defined by not having any changes in the DNA of a gene called the RAS gene. So we call that gene wild type. It's not mutated, it's not changed. Now, everybody got the chemotherapy for a period of 4 months, and then at the 4-month mark, in one group, one of the drugs, the one that causes the nerve damage, is stopped. Because that's usually what we do. We don't usually keep that drug going indefinitely because of the nerve damage. But they continued with both the chemotherapy and the antibody treatment in a strategy that we call maintenance treatment. It's a way of keeping the cancer under control for longer. In the other group, they said, well, you know, maybe if the cancer is RAS wild type, maybe we don't need the chemotherapy. Maybe the antibody on its own is actually enough, and we can cut out one of the drugs. So they asked the question, do we need to continue the chemo? Is the antibody alone effective enough to keep this cancer under control for longer? So this time we did see a difference that actually favoured continuing the chemotherapy with the antibody. The antibody alone didn't perform as well. That decision about what you do at the end of those 4 months of chemotherapy is complex. But this sort of information can guide you and guide your patients in your discussion. Some patients will decide to stop everything and have no treatment. Some will want to continue treatment. I think with this, at least, you'd be steering patients away from just continuing the antibody. You'd want to keep going with the chemo with or without the antibody. So we need that kind of information, because at least it kind of takes off one of the options, I think, that some people were thinking about. This is what the poster area looks like at ASCO. And one of the really great things about the posters is that you get a chance to really talk with the investigators. You mingle, you walk across, you discuss posters together and the results together. But it's huge, it's massive, it's a bit of a maze, there are people all over the place. But it's intellectually very stimulating. And one of the posters that I came across, kind of saw this, it was the Saturday morning, I caught up with Prunella Blindman, who's a medical oncologist here in Sydney. And Prunella led a very interesting research project where she looked at patients that were involved in one of the studies that the AGITG was involved with. The study that looked at giving chemotherapy after bowel cancer surgery. And patients in this study were assigned to either have a 3-month course or a 6-month course, 12 weeks, 24 weeks. So the study was asking, is 3 months as good as 6 months? But the group led by Prunella also wanted to ask patients something else. She wanted to ask them, if the 24 weeks is better than 12 weeks, how much better does it really need to be? Is a 1% improvement enough? Is 10% what you're after? Is 50% what you're after? And so she asked the same sort of question in many different ways, but the results were interesting and pretty much the same. So there was a variability in the responses. One of the things that I found really interesting, and this kind of says a little bit about how we decide on things, and kind of, it depends a bit on kind of where you are, and there's interesting psychology behind this. But if you look at this area here, the light green is higher than the dark green. The numbers are small. This is really saying that if you're going to survive 65, if there's a 65% chance of long-term survival, how much of an extra survival rate do you need before you say you want the 24 weeks? If the 24 weeks gives you no extra survival, do you want 24 weeks? If it gives you an extra 1% chance of long-term survival, do you want the 24 weeks? Or would you just stay with the 12 weeks? If the 24 weeks gives you 2%, 3%, 5%, and so on. So it's trying to ask the patient, what is the kind of level where you'd say? And these are patients that have been through the chemo. They know what the chemo is about. Now, some of them were on the 12-week arm of the study, and some were on the 24-week. And the light green means that they were on the 24-week, and the dark green means that they were on the 12-week. And I just found it interesting that, when you start talking about a 1 or 2 or 3% benefit, that's pretty small, even 0%, which is no benefit. But you've still got a number of people in that 24-week saying, yeah, I'll take that. And I think they're just saying they're kind of happy where they are. Maybe they're just sort of expressing an acceptance of where they are. Maybe that's what that's about. When we get to the 50% mark for patients, so that's where half the patients are prepared to accept 24 weeks of therapy over 12. They're really looking for a benefit that's in the order of about 10%. So that 50% mark kind of meets around here. So it just gives us an idea of the magnitude of benefit that patients are really seeking, to kind of turn around and say that's worth it, given the side effects and the risks and the inconvenience. So I think that kind of information is important. Now, everyone's an individual, and there are variations, but I thought that was really interesting. And that was led from an Australian group through the AGITG and part of the Scott study. So I think that's pretty much all I've got to talk about around colorectal cancer. Having said that, I'm very happy to take questions from the audience about anything that I've talked about and about anything else to do with GI cancer. Thank you.